Hello, everybody. Can everybody hear me okay? My name is Deb DeBruin, and I am the Interim Director of the Center for Bioethics, and I'm happy to see you all today. Welcome to the first installment of our Ethics Grand Rounds for this academic year. One quick announcement, well, two quick announcements before I introduce our speaker. One is that there's a sign-up sheet in the back for biomedical engineering students. So if you'd like to get credit for attendance and you are a biomedical engineering student, please be sure to sign in as you leave if you didn't already sign in on your way in. The second announcement is about our mini Bioethics Academy, which is our community education series. We had our first event last week. The second event in the series is tomorrow night. There's information about the series on the foam core, the poster, just outside the door if you want some information. Otherwise, feel free to ask any of us. Tomorrow night's event is about ethical challenges in home care. And then the final event in a week, I'll be presenting on public health emergency planning. Okay, without further ado then, I will introduce our speaker. I have to say that I am really genuinely delighted to introduce you to one of our own, Dr. Amos Laar. Dr. Laar is a graduate of our Bioethics Master's program here at the U of M. He also has academic training in nutrition and public health. His research is quite interdisciplinary and draws on the social sciences, bioethics, and public health to understand how the physical environment, social environment, and structural forces affect health. He's a very productive scholar, having published 1 book, 5 book chapters, and 62 journal articles. Dr. Laar spent most of the past decade exploring the cultural, ethical, and public health dimensions of HIV, so that work related to the work he's going to present to us today. He has led or co-led a number of grant projects related to HIV. In addition, Dr. Laar was one of 2 experts who supported the development of Ghana's approximately $78 million global fund grant for HIV and TB for the period of 2018 through 2020. And in 2017, he supported UN AIDS to develop Ghana's fast-track HIV prevention roadmap. His more current research focuses on 2 distinct yet related areas of public health ethics, including health and human rights, food ethics, and nutrition rights, and public health nutrition, including food literacy, nutrition-related illnesses, and the nexus between food, environment, and health. Dr. Laar is the president of the African Nutrition Society, and he was recently recognized in The Lancet for his efforts at combating nutrition-related non-communicable diseases in Ghana. He is also the co-PI and the Ghana lead on an NIH-funded project which will establish a master's program in bioethics at the University of Ghana, which will be the first such program in Ghana. He's a busy guy, as you can tell. We're very proud to include him among our alumni and are so pleased that he's here with us today. Please join me in offering him a warm welcome back to Minnesota.
Thank you, Deb, for your kind introduction. This is what you get when you get your favorite lecturer introducing you to speak at a conference. So I would also want to use this opportunity to express my thanks to the Center for Bioethics for the opportunity to engage you on some aspects of Ghana's national response to her HIV epidemic. I aim to make a case for a meaningful integration of the social into what is currently predominantly a medical response to the HIV epidemic in the country. A response that respects not rights of the socially excluded, a response whose guidelines are not socially responsive. I would proceed this with some notes on history and the current outlook of the global response to HIV. In 1981, of course, I was too young to have heard, let alone read about what we know today to be HIV or AIDS. And I bet you the adults who were in Ghana at that time, I don't know how many of them had heard of AIDS. The very few scientists in the USA and Europe who were working on this disease didn't even know what to call it. You know it all. I don't have to waste your time on this history. What though I would want to note is the fact that these bigger epidemic of HIV came with it smaller epidemics, epidemics of fear, epidemics of stigma, epidemics of discrimination. Unfortunately, these smaller epidemics have endured. And that is why it's important to acknowledge the contributions of, of course, several people. There's no way I'll be able to name all, but I've chosen just a few who have contributed, I think, in my view, meaningfully to the fight against HIV in the US, globally, and of course in Ghana. And so to my left, I think that is your right. To my up there, Everett Cope, based on what I have read and have heard, contributed meaningfully to educating the Ghanaian US public on HIV. I'm told he was once a US Surgeon General. In the middle is Professor Jonathan Mann, who I'm sure you are aware was one of the few who stood up for the rise of HIV positive persons during those early days. And last but not least, Professor Peter Lamte is a Ghanaian, with funding from US government's money, was able to contribute to letting the group know that it is possible for antiretrovirals to be delivered in resource-poor settings. And so in Ghana in early 2001, with funding from the US, he was able to demonstrate that nurses and low-cadre health professionals were capable of delivering antiretroviral therapy to HIV-positive persons. And so from those early beginnings till now, 2019, we have learned a lot about the disease. Those days that we didn't even know what the causative agent was, now we do know, and it's HIV. Scientists have actually sequenced the entire genome of HIV, which we know now. And HIV is now just one of many chronic conditions with several medications that we can effectively treat it. Globally, if you look at the response since the 80s, we have made significant progress. The year reference here is 2015, and data from the UNAIDS show that between 2000 and 2015, the global response has resulted in a reduction of new infections by 35%. In adults. And if you look at that in children, it is even higher, close to 60% reduction in new HIV infections among children. If you look at AIDS-related deaths, from its peak in 2004, between 2004 and 2015, a reduction of over 40% in AIDS-related deaths. And then for antiretrovirals, between 2010 and 2015, a whopping increase of over 80% in terms of access to antiretrovirals. Great strides, great achievement. With those achievements, there are still gaps, there are still challenges. And some of the challenges are what I'm going to talk about today, which relates to the fact that we have emphasized an aspect of the response, leaving the other, which is the social. But before I talk about the inequities, those inequities, even within the medical response, there are even still gaps. And so in 2014 in Melbourne, Australia, the UNAIDS adopted what we now know today to be the 90-90-90 roadmap or strategy. And what does it entail? That between 2014 and 2020, nations, states, counties, districts should put measures in place to ensure that they have diagnosed 90% of all those who are HIV positive. That's the first 90. And the second 90 is that all those who have been diagnosed to be HIV positive should have access to antiretroviral treatment. And then the third 90 is that of those who are receiving treatment, 90% of them should have sustained viral suppression. And so globally, we're all, as nations, as public health professionals, tasked to ensure that these targets are met. And the year reference, 2014 to 2020, which is just next year. And how is the world doing? As you can see here, this is how far we have come. And so a midterm assessment was done in 2016. And so globally, you can see 70% of those who are HIV positive know their status. So we still have so many people who are HIV positive that don't know. 77% of them are on treatment. And then of those who are on treatment, a little over 80% of them have sustained viral suppression. This is global. Sometimes aggregating these numbers, hides local level disparities. And so I'll talk to you soon about how Ghana is doing with respect to this 1990. But before that, I'm sure there are a few of you who may not have heard of Ghana or may not know much about Ghana. And so I would want to take a minute to let you know it's a small country, relatively, compared to the US. The first to have gained independence from East colonial master, that was Britain. Until recently, we used to have 10 regions. Just last year we did, sometime this year, early this year, we had a referendum, and now there are 16 administrative regions. These regions are subdivided into metropolitan, municipal, and district assemblies, 117 of them. The population is around 30 million. The last time we did a census was 2010. We are planning to do one this year. Most of them are quite a significant proportion of the Ghanaian population are young, are 40%, and about 40% of us also live on less than $1 a day. So some background information about Ghana. Although quite a chunk of what I'm going to say would qualify as self-bashing, there are a few things that Ghana as a country did that I think deserve praise. And so in 1985, even before a country we recorded the first ever HIV or AIDS in the country, structures had been put in place in anticipation for diagnosing an HIV positive person. And so in 1985, the country set up what they refer to as NAC, National Advisory Council on HIV. There were just a few eminent researchers and scientists and then medical doctors who were put together to advise the government on how to respond to such an epidemic at that time. And then in 1986, that was when we first recorded an HIV or AIDS in the country. Just as it was in the US, it was the same during those early days. The epidemic was met with mystery, suspicion, stigma, judgment, discrimination, and then fear of the unknown. Unfortunately, as I indicated, some of these are still relevant today. And in 1987, as a country, we started having our fully fledged national program to fight HIV. So NACP, National HIV and STI Control Program in 1987. 13 years after, when the country recognized, and of course the globe had also recognized, that HIV was not just a clinical condition, it was not just an infectious morbidity, it was more than a clinical condition, it was a developmental problem. So that led to the formation of Ghana AIDS Commission. And so since then, Ghana AIDS Commission has been coordinating both the medical and non-medical response to Ghana's HIV epidemic. The commission came out with a series of frameworks, so National Strategic Framework, that's what NSF stands for. So they had one between 2003 to 2005, a second one from 2006 to 2010, and this framework were what were used to guide the country in its response. The frameworks metamorphosed into what we now refer to as national strategic plans, and we had one from 2011 to 2015. We currently have one that guides our response from 2016 to 2020. So this strategic plan outlined strategies and activities to achieve treatment as well as prevention target. It's ascribed to the 1990 fast track target I talked about. It also respects the treatment as prevention, philosophy, and quite recently, the test and treat or strategies. Apart from that, the country has come out with a campaign. They came out with a roadmap for the 1990, which is referred to as L2TSR. So locate, test, treat, and retain, which we are implementing. Of course, to implement something like this will require a lot of resources, and Ghana doesn't have the resources. At least that's what our leaders say. And so we rely on bilaterals, for example, PEPFAR, US President Emergency Plan for AIDS Relief, a lot for the interventions that we implement in Ghana, and also Global Fund. Between 2014 and 2017, you can see PEPFAR, so this is US money, had invested nearly $150 million in our AIDS response. This is a lot. And with this huge investment, there must be some resource. Here, I would show you some of the, I don't know what to call them, achievement, but some of the dividends of those investments. In Ghana, if you ask programmers, policymakers, and even some researchers as to what are the indicators of success, or they run to the prevalence. And so you can see here a trajectory of the HIV prevalence in Ghana from 2001 up to 2016. And so from a highest peak of 3.6, these are national figures, so national prevalence of HIV. From 3.6% in 2003, it is hovering around 2.4 now, currently. And so as far as prevalence is concerned, this is how Ghana is doing. And so these percentages sometimes don't give meanings. So what does it mean? We have currently over 270,000 people living with HIV in the country. And what interests me most of the time has to do with, see, the new infections. So you can see 12,000 annually, and the deaths. So of these 12,000, 10,000 are adults, and then 2,000 are children. Okay, so the question therefore is, are we on track as a country? It's a difficult question for me, and I have never been able to, answer this question convincingly. It depends on what you are looking at. If you are looking at the 1990, I talked about, this is how far we have gone, we have come. And so as of June 2019, other than getting 90, we have 66, 60, and 67. And so are we on track? The numbers will speak for themselves. If we look at treatment access, although a lot has been done to improve treatment access, we still have over 2/3, about 1/3 here having access to antiretrovirals. Although in 2016, 100,000 were put on treatment. If you relate the 100,000 to the 270,000, you see that quite a number are still not on treatment. Annual number of deaths or AIDS-related deaths, although has decreased from 25,000 to 15,000. 15,000 is still a lot of numbers of deaths. ART coverage among children has increased, but we still have so many children who are not having access to antiretrovirals. Apart from that, people sometimes refer to this as vengeance. So we are now seeing a new HIV infection rising among adults in the country. When we looked at our national representative surveys conducted over the past couple of years, we see an 18% increase between 2008, 2010, and then 2016 increase in HIV. And most of these new infections are traceable to sexual transmission, not pediatric. There has also been a decline in comprehensive knowledge of HIV. Of course, awareness of HIV as a condition is very high, nearly 100%, but then in-depth knowledge of that condition is very low and is decreasing. And so, how did we get here? How did we get here? Is the question that several countries, not only Ghana, is asking. Because some of the indicators that I just presented to you are not peculiar to Ghana. And there are a number of reasons. Some have argued that we got too excited about some medical interventions that we got, which are working, and we do support them. But I think the only problem is that there's a disproportionate, emphasis on the medical, leaving the social. And it didn't just start today. If you look at what even becomes newsworthy as far as HIV research, HIV interventions are concerned, most of them are medical. You wouldn't get papers looking at the social aspect being published in top journals. And so I just picked a few from 2013. You can see the headlines. Scientists may have created the first HIV vaccine, medical. 2014, HIV cure breakthrough. Temple University researchers eradicate HIV virus in human medical. HIV is losing its edge, evolving into milder form, study finds. Medical. US doctors perform the first HIV to HIV liver transplant, medical. There's in 2018, there's no cure for HIV, but scientists may be getting closer to it, medical. In 2019, and I was happy to see this in 2019, that HIV is deaths fall by 1/3 since 2010. But experts say more could be done. It is on this note of more could be done that the cases that I'm about to make hinge. And so if more has to be done, more needs to be done in what we are doing now, which is mainly focusing on preventing HIV using treatment. So preventing HIV in the posters. In Ghana, for example, 10 years, 20 years ago, you could see a billboard and other primary prevention activities. Now, you come to Ghana, you wouldn't see even a single one. And so this is one of the reasons why the numbers are changing, and we are getting a reduction in comprehensive knowledge, and we're also getting increases in new infections. And I have no problem as an individual against treatment in imposters, or treatment as prevention, as we call it or refer to it. We do have public health justifications for treatment as prevention, and it works. For those who may not be familiar with this terrain, so 2008, 2010 studies were conducted that show that if you treat HIV, there are actually several positive externalities. So the person who is treated benefit, but those in the community who are not even HIV positive also benefit, because we do know the single most important determinant of HIV transmission is the viral load. And so once individuals who are HIV positive get treated, their individual viral load reduces, and then you have several people in the community whose viral loads reduce, then the community viral load also reduce. And these makes those HIV positive persons not able to infect HIV inactives in the community, which is good. And we are implementing that. The only problem, as I keep to emphasize, is the fact that we are only focusing nearly 100% on the medical and leaving the social out of it. We have a biennial conference in Ghana on HIV. And just last year, in 2018, before my talk, I did a quick survey among policymakers who were there, students, researchers, on the 1990 I talked to you about. And refreshingly, 100% of those I engaged knew about the 1990, which is good. But the 1990 they knew is the 1990 I've talked to you about so far. We do have other set of 1990. And unfortunately, most of them had no idea about this blue 1990. I've talked about the red 1990, right? So this blue 1990 are a bit social. It is interested in reducing new HIV infection by 90%, that is by 2030. And so also by 2030, there should be 90% reduction in stigma and discrimination. You don't get to hear about this 90. By 2030, there should be 90% reduction in AIDS-related deaths, of course. So this red 1990, the deadline is 2020, the blue is 2030. But you don't get a lot of people talking about the blue 1990 because of our overemphasis of the medical over the social. And so this is one of the justifications for the three cases that I aim to make. And that first case is that as public health professionals, as nations, as nation state, we should endeavor to have meaningful integration of the social into what we currently do, which is predominantly medical. And this case is grounded in the philosophy of social public health. The concept is not mine. The first time I saw it was a publication done by Henderson et al., looking at enhancing HIV prevention, that it requires addressing the complex relationship between prevention and treatment. And so social public health, as they put it, resonates very well with today's public health, which is interested in empowering communities. SPH, which is not School of Public Health, Social Public Health, sorry, recognizes people not only as individuals, but as connected members of their groups, of their networks, of their societies. And these are individuals who talk. These individuals negotiate, these individuals have sex, they use drugs, they go to churches, they go to mosques, and they do all kinds of things as individuals and also as members of their groups. And so if we have to intervene to respond to HIV in ways that destabilizes these, they may not respond in the way that we want. And so we need to understand how they would respond to us, for us to be able to have our interventions to be effective. And so people would respond to our interventions as members of their communities in ways that would enable them to remain as members of their communities, to remain masculine, to remain married, to remain Christian, to remain Muslims. And so if we only focus on the efficacious medical responses or interventions, we may have them not being effective. And it's one thing having an efficacious intervention and another having it being effective. And that is why I argue that it is good to have effective medical intervention, but we need the social to have them being effective. A colleague of mine and I contributed a book chapter to a book by Public Health Nutrition, and this was focused on nutrition and HIV. And we couldn't but emphasize a conversation with an HIV positive that we had. And she notes that if you take away my food, you would kill me faster than just taking away my antiretrovirals. Of course, antiretrovirals are important, but to some of them, food is even more important. And food insecurity is a big problem in the country. It's even more of a problem among HIV positives. And so in this other chapter, we looked at food insecurity, not only among HIV positives, but among their significant others. And so people may be infected, others may be affected. And so HIV induced food insecurity is not only a problem among the infected, but it also affects what? The uninfected. And so if our interventions, our responses are only merely medical, focused on the infected, we may be losing or missing the boat. I had an opportunity to be engaged by the United Nations World Food Programme to do a nationwide assessment of food insecurity among HIV positive households. And so from this work, it revealed a number of disturbing things, including the fact that in response to food insecurity, you have household members instituting dehumanizing coping strategies. For example, over 60% of the households we engaged indicated that to respond to food insecurity, they would have to limit portion sizes. They would have to reduce the number of meals that they eat in a day. They'll have to rely on less expensive food, and household members have to be sent out to go beg. And this is dehumanizing. These are, things that the medical alone cannot address. We need the social. We delved further by engaging a few of these who reported in the quantitative study, in the qualitative study. And one thing that came out that I would want to share with you was that one of them indicated that they just cope and hope that things would change one day. So they are coping with food insecurity and hoping that one day things will change. Who would change this? This really touched us a lot. And since then, we have been doing the little we could to ensure that things change, not only for us, but also for them. But for these things to really change, we need to understand the social. Before I talk about my second case, I would want to present findings of a study that was done by some of my colleagues in Ghana. And the title is a bit provocative, All Die We Die. In Ghanaian parlance, in Ghanaian language, when we say all die we die, what it means is whether you are dying from HIV or dying from road traffic accident, that death is death. It really doesn't matter. And for public health practitioners to appreciate these, they would need to have the social they need to appreciate this to have the social integrated into their responses. These researchers followed young female sex workers. And one of the female sex workers, 16 years old, indicated that some people are going to die anyway. It may not therefore matter much what you are dying from, whether it's HIV or not. So dying from HIV to her is just as a problem as dying from hunger, and therefore she would not stop commodifying her body as a sex worker because she needs to eat. And where does she get her daily bread from sex work? These are things that I think public health practitioners need to be aware of as we prepare to respond to our HIV epidemic, wherever we find ourselves. I'm focusing on Ghana. The second case I would want to make relates to the fact that, as I indicated, our response over the years have not respected the rights of the socially excluded. And in Ghana, based on her, have a century penal code, populations that we refer to as key populations are currently criminalized and are being penalized. And these key populations, they are referred to as key populations because they are key to the response to HIV epidemic. They have higher risk of acquiring the infection, and they also have higher, chances of they are efficient transmitters of the epidemic, and so they are key. Unfortunately, as a country that criminalizes and penalizes some of these populations, we wanted to know how services could be delivered to them. And again, with funding from US to USAID, measure evaluation based at UNC came to Ghana, and we jointly implemented this. We documented how services were being delivered, and it would be of interest to you to see that to circumvent these, the Ghanaian healthcare delivery system had to engage non-state actors to be able to deliver services to these populations that are, legally outlawed. We engaged a number of stakeholders, and what came out of that stakeholder engagement was that we needed, as a country, to scale up efforts to address social, cultural, religious, political, and then legal barriers to HIV prevention efforts, especially among female sex workers and among men who have sex with men. Following this, Deb and I did a piece. We had to submit an argument to BMC, International Health and Human Rights, to argue for the rights of these key populations in Ghana. And our arguments were grounded on the principle of harm reduction. So we invoked the humanistic and the neutrality principles of harm reduction to request that the Ghanaian government respects the rights of key populations, especially their rights to public health services. I haven't mentioned this today, but following this publication, I got very interesting, feedback from a couple of stakeholders. And so there was one group of stakeholders who were angry about this publication, and they contacted me and said, I have changed. I've changed because I'm now an advocate for men who have sex with men and for sex workers. And they were angry. On the other hand, these sex workers we have engaged for years, and we still continue to engage them. Some of them were happy that they have found their voice in someone, in a paper like this. And so, interestingly, one of them at a meeting told me that, we have followed your work and you have been with us. Being with us means I have done research with them for several years. And we always see you as a taker, unquote, as a taker. And taker means we use them to meet our needs. and not their needs. But this particular paper makes us rethink our characterization of you as a taker, and now you are a giver. I just couldn't believe that. Yes. So, but for my colleagues who were angry and these key populations who said what they said, I think both of them actually do not understand why Deb and I did this paper. We did the paper based on our appreciation of the Ghanaian HIV epidemic. Over years, we have gotten evidence that show that key drivers of the epidemic in Ghana are high level of multiple concurrent sexual partnerships with low condom use, and then 2, marginal access to HIV prevention services, especially among these key populations, and then also enormous stigma and discrimination against same key populations. And therefore, we needed to address these drivers. And by addressing these drivers, such paper and others are needed. Indeed, we further understand our key populations even better, because the Ghanaian MSM, for years we have argued that they are a bridging population. Why are they a bridging population? They are because they are MSM, but they have wives. They are MSM, they have girlfriends. They are MSM, we interact socially. We even interact sexually. And if you look at sexual network maps or diagrams like this, it really doesn't matter whether you have interacted with that MSM sexually. If you haven't interacted with him sexually, but you have interacted with this lady here sexually, you might as well have interacted with him. And there's a possibility that if this person is HIV positive and he has interacted with these and all these other interactions, then your chances of also getting HIV from this particular single person is not 0. Yes, and so that's why we need to address their problems. And we say whatever affects them directly affects all of us indirectly. Then the last case, my third case. This third case actually relates to work that I got mentoring from some of you here to do when I was a student. And so Deb, Lieutenant Alan Lipson, and Steve Miles were my MA advisors. And so they guided me to do this analysis of policies in Ghana to see how ethically responsive they were. And some of the findings included the fact that rights violations were rampant in Ghana, and yet there were no policies to guide or address it. We also found deficiencies in the fact that there are scarce resources. As you saw, only 34% of those who need to have antiretrovirals have. Yet we do not have guidance as to how that scarce resources should be, ethically shared. Since then, just before this talk, I went back to those same policies, and there are new policies, and there are even newer problems. And those new problems include the fact that we still are focused on our interventions, those medical interventions I talked about, and even if they are social interventions. When we focus on interventions and not programs or prevention programs or treatment programs, we miss a lot. We miss a lot in that we implement them vertically, sometimes in silos. Interventions by their nature would be, say, behavioral interventions, it could be structural interventions, it could be biomedical interventions, but they do not link the epidemiological with the social. And that's why we are arguing, as part of this argument for meaningful integration of the social into the medical, we should be focusing more on programs other than on interventions. As I indicated, you can have an efficacious interventions. Once that intervention is not properly delivered, it will not be effective. And so our baby steps in ensuring that we infuse or integrate the social into the medical in Ghana. A number of researchers at the School of Public Health, University of Ghana, and other affiliate faculties came together to form what we refer to as HIV Interactive Training, Education, and Development Center. We got funding from the World Bank to set this up. And one of the things we were interested in doing is to address that gap of low AIDS literacy. So we set up a nationwide toll-free line that people could call in and get information on HIV. We engaged various stakeholders, including chiefs. We even worked with the Ghana Health Service to implement their Know Your HIV Status campaign. And so at the School of Public Health, these photos are taken from School of Public Health, where people could come and test for HIV. As I indicated, we engage queen mothers, we engage chiefs, we engage community members, we engage healthcare professionals in one of the communities that is highly, burdened by HIV in the Eastern region. All these efforts led to the formation of what we now have today as HIV 360 Research Group. And this group comprises researchers and also practitioners who are working together to provide guidance or advice, especially to the Ghana National HIV Control Program. They are also members of the HIV 360 group. And we have continued to advocate for, having lessons we have learned from the past to guide our national response. Lessons that were successful should be scaled up or maintained. Those that were not should be left out. And that is what that group has been doing for some time now. To conclude, I do think this call for meaningful integration of the social into the medical is not a fight for equality. It is about equity. We are not saying the medical shouldn't be delivered, but it should be delivered, but that should be sensitive to also the social. And we think it is the only way that we can have a sustainable response to the HIV epidemic. If we focus on only the social, it is going to be, as it says, mopping the floor other than closing the tap. And if we focus on only the medical, it's going to be the same thing. And therefore, we need both the social and the medical. I attended a conference some time ago, and there was a presenter who said ending AIDS as a public health problem cannot be done within our lifetime. He indicated it is possible. It is possible, and that can only be done when good things align. We at the HIV 360 Research Group believe that a marriage between the social and the medical is one way of getting these things done. So thank you very much. I would want to particularly express my sincere thanks again to the Center for Bioethics for giving me this opportunity to share my thoughts on what we are doing right or not right in Ghana nationally. And of course, as you saw in the presentation, some of the aspects of what I presented benefited from my MA work that was supervised by Professor De Bruin, Professor Alan Lifson, Professor Lee Tenner, and Professor Stephen Miles. Over the years, I have gotten funding from several organizations. I haven't been able to list them all, but work funding from HIV Research Trust based in UK, funding from USAID, funding from WFP, UNAIDS, and others. Ghana AIDS Commission have contributed to the work that I do in Ghana on the HIV epidemic. So thank you once again.
So at this point, Dr. Laar will take some questions. Because we are recording for posterity and also streaming to coordinate campuses today, I'm going to ask that you use the mic when you ask your question. So if you can just let me know if you have a question to ask, and I will do my best to race the mic to you as quickly as possible.
Hi, great talk. Thank you for that education. Just on the 90-90-90, what do you think the biggest barrier is for the first set of 90 to be identified? And then from the viral load, a lot of these individuals will carry the virus through their lifetime. Does that mean they'll always transmit it? There's always that risk that they'll carry it forward. Even young children that are diagnosed and, no fault of their own, have it at an early age. Maybe you can answer those questions separately. Okay. Thank you.
Thank you. Thank you. These are really very useful questions. The 90-90-90, as a number of people have indicated, were really ambitious. Your question relates to what is it that is the biggest barrier to achieving the first 90, which is that we should have 90% of all those who are HIV positive getting diagnosed and knowing that they're HIV positive, which is the first step if you have to get people treated, right? You can't be treating the entire population. You have to treat those who are HIV positive. In our setting, I don't know about the US, but in the Ghanaian setting, the major, barrier to these are actually social. They are socially related. It has to do with the stigma that I talked about. So one stigma, once you have been diagnosed to be HIV, and we have different layers of stigma. We have self-induced stigma, self-stigma, and there's also stigma from without, so stigma from community members. So stigma is a major thing. The second problem with even the entire 1990 framework in Ghana is the lack of resources to ensure that those who get tested get treated. People have asked in the past, what is the point in getting tested if I cannot get treated? Of course, there are several benefits even if you don't get treatment. But to the individual, some of the questions they would ask themselves would be, so I get tested and I don't have access to treatment, how would that affect me individually? So discrimination, stigma and discrimination, we sometimes usually talk about them together, is a major barrier. The second question about viral load and HIV transmission. Yes, viral load based on scientific studies is known to be the single most important determinant of someone transmitting the virus to the other. So if the viral load is very high, your chances of transmitting is also very high. If it is very low, your chances of transmitting also becomes very low. There are times when it becomes low to the extent that then that person is not capable of being capable of transmitting the virus to another person. But that does not mean that person has been cured. There were studies, I think, the early days of HIV done here in the US, where they identified a few people to be what we refer to as long-term non-progressors. And so they are HIV positive. They probably are not on treatment, yet they don't become, they don't have frank AIDS. And their viral load are also kept controlled, although they are not on treatment. So the viral load is important in determining whether HIV can be transmitted to the one person to another, but there are other determinants of HIV transmission.
Dr. Laar, thank you for your presentation. I really appreciate your outlook, particularly from a social public health viewpoint. Reflecting back on your statement, all die, be die, do you sometimes feel an overwhelming push towards addressing HIV or addressing community-based problems? Because I've seen that a lot of times the push from funders and others are so single disease focused that we forget that the community may not really care for it. So what's your take on that?
Thank you. Can you help me get the first part of the question?
I really appreciate your presentation. Okay. Thank you for that. Social public health. And you mentioned that all die, be die. Mm-hmm. I think that's such a powerful statement. My concern is with the funding agencies and others looking at single disease approaches, are we forgetting what the community might really want?
Exactly. Thank you. And yes, the core emphasis of these presentations and then the work that we have been doing in Ghana as part of the HIV research group, I think is critically important for all of us. So public health practitioners and funders alike, to recognize that focusing on HIV as a disease whilst leaving what is it that contributes to that disease is a mistake, because there's no way we are going to be able to address the problem if those entrenched social practices, even concept of what a disease is, concept of how a disease can be treated or cured is not addressed. And so as those young ladies indicated, if you want me to stop commoditizing my body as a sex worker, would you give me an alternative to address my nutrition needs? She's not thinking about HIV as a health problem. She's thinking about what affects her life even more pressing than HIV. And so funders need to be aware of this. I think they do. Probably it's just a matter of time, and we probably need more advocates to let them understand that we are not going anywhere if we focus on the status quo, which is that over medicalization of any condition, whether HIV or TB or any other condition, is not good.
Thank you very much. I really appreciated your talk. You mentioned, we talked about one of the biggest barriers for the first 90% of the 90-90-90 was stigmatization of the disease. And we looked at the uptick in the disease in the last few years, and you paired that with a lack of actual facts of the disease across the country, as opposed to maybe some pseudoscience or rumors that spread. Is there any effort by GES, the Ghana Education Service, to address these facts at a younger age in school? Or is there any funding going towards education early on, or just education broadly on that aspect?
Yeah, excellent intervention. And the global HIV coalition's work that has been done in several countries, including Ghana, I think Deb in her introduction of me indicated I supported the UNAIDS in Ghana to come out with their roadmap. When we engaged stakeholders, this actually came out, and it came out so forcefully. There's a saying in Ghana, which may not make sense to you here, but it says, catch them young. Catch them young means, integrate into their psyche, the educational system, their appreciation of, and now we are focusing on HIV at that young age, so that when they grow, they would have that knowledge. So it was one of the recommendations that we captured in that roadmap for the fast track target related to just HIV prevention. And so it's important. Unfortunately, that is where the problem is. Unfortunately, I don't think Ghana as a country has paid heed to this. And so some of the health-related topics that were even part of our curricula at the basic levels, we just had a few months ago, got it reviewed, and there are some that are actually being taken out, including nutrition and others. And so as a country, we are not, of course, we are doing a number of things that may be right, but there are a couple of things, including this, that I don't think we are doing right. We need to introduce, and not HIV, if we have to introduce, disease by disease, we'll have the curriculum, overcrowded or crowded with so many. But we can have maybe a generic health education bit that addresses several diseases, including HIV, which currently is not the case. But I do agree with you, it is extremely important.
Once again, thanks a lot for the talk. I have so many questions, but I'm just gonna ask two. And first one is about PrEP. I'm really curious about how did PrEP affect the field, and affect how does HIV look like, an epidemic look like, and especially prevention and treatment look like right now in Ghana. One thing that I'm thinking is that PrEP is also critiqued a lot for opening the way for further medicalization of HIV. Right now, not as it relates to HIV positive people, but as it relates to HIV negative people. So when we're talking about putting medicalization aside for a second and to focus on the social aspects of the problem, like how does PrEP actually affect this picture? And also, does it create some discussions around rationing? Because I guess if you mentioned, I missed it, if the antiretroviral treatment is available for free, and if not, how does the introduction of PrEP right now actually affect all that discussion? In terms of, are we going to provide that to HIV positive people, or are we going to provide that to negative people who are at risk? So that's the first question. And the second question is related to my work. I also work on a similar topic in Turkey, where we have 450% of increase in incidence in the only last HIV incidence in the last 10 years. And I'm working on what I call the epidemiology of conservatism, and how government's conservative values are actually, to a very certain extent, are responsible from the epidemic. In terms of how sex education, for instance, sex education and condom use are either prohibited or restricted. So you mentioned briefly the criminalization of homosexuality and sex work, but I'm really wondering, how does this, what is the exact role of states' conservative values and practices in failing to address the epidemic? What does it look like in the field? What kind of actions, you as also a practitioner in the field, you would like to take but cannot take because of this political framework?
Okay.
Thank you.
Thank you very much. But these are very relevant questions. On the subject of PrEP, Ghana is an interesting country. As a country, we are very efficient in signing up to guidelines that are developed globally by WHO and others. And so when the data on PrEP started coming out, and of course not at that time very convincing, there was no consensus, global guidelines on PrEP were developed, and Ghana was one of the very first, paradoxically, one of the very first countries, that signed up to, using pre-exposure prophylaxis as, one of the response mechanisms. And, this raises a number of ethical questions, social questions, even programmatic challenges. And as a student here a few years ago, we did read, publications authored by Ruth Macklin and a professor from South Africa, Gerald Singh, looking at this issue of PrEP and whether or not it is ethical to divert the limited resources. You remember I told you only 34% of HIV positive persons in Ghana have access to antiretrovirals. So is it really ethical that we divert some of the limited resources from HIV positives to HIV negatives? Of course, these ethicists had their go, and there was a lot of back and forth. You can't have just one response to a question like this to say that it is ethical or it is not ethical. It needs to be, discussions need to be nuanced. In the context of Ghana, although I do understand that it needs to be nuanced, if you take as of my personal opinion, I think I would stick out my neck and indicate that we shouldn't go the PrEP way, but I do not have that power to tell them that no, PrEP is not the way to go. I'm not against PrEP. I'm not against the science of PrEP, but the logistical, the programming challenges associated with it is a problem. And the fact that we do have a lot of people that we know are HIV positive would come to the facility for antiretrovirals and we didn't get them. Diverting it to those who are not ready or are in need of it right there and then would be problematic. Of course, there are other arguments about how scarce resources should be allocated. Yeah, is it based on agents' need? Is it based on paritarian principle? Is it based on first come first served principle? All these are things that when we are having serious conversations as to how such resources should be allocated, we need to have all that at table for not individuals but groups or communities to give their contributions as to which would best fit their circumstance. PrEP may be efficient or useful, for example, in the US. In the Ghanaian setting, it may not. And so settings differences need to be taken into consideration. Exciting work about what you are doing in Turkey. Very interesting work. Okay, so I got so excited about what they are doing in Ghana. I think the last part of the question, I'm blanking on that.
Yes, I was asking, so for instance, there are so many things that we are, like as the practitioners or activists are trying to do in the field as in terms of trying to increase the use of condom or provide sex education, and we cannot do these things because the government does not allow us. Mm-hmm. So are there things like that that are specifically materially affecting the response to HIV in Ghana?
Okay. Yes. It does. And the work that I showed in my slides that we did in collaboration with Measure Evaluation actually identified a number of, should I call them, innovative ways of getting services delivered to key populations using other channels. So The laws are there. It's difficult to get those laws repealed, but there are instances where all those laws exist. Arms of the government would not really implement them. And so you have Ghana Health Service as the health service delivery, agency of the Ministry of Health. Those who are managing or overseeing Ghana Health Service are government employees. They value their job and would not want to violate the laws of the country, and wouldn't openly come out to say, sex workers, where are you? Come, we have interventions for you. Men who have sex with men, we have interventions for you. But would rather engage NGOs. And so they would work with NGOs through backdoor for the NGOs to deliver their services. And so that is one way Ghana as a country is able to deliver some of these services to them. But truly they do affect national HIV response and HIV service delivery. There are times, sometimes you have Ghanaian police at midnight swooping on, what we call hotspots, where sex workers congregate to ply their trade, and sometimes NGOs deliver their services at these hotspots. And there have been instances where service providers are misunderstood as sex workers and are arrested. And so such actions by the Ghanaian police services, you can see, can directly influence whether or not other NGOs be interested in providing services to them. But as I indicated, the innovation in Ghana is the fact that NGOs are doing the service delivery in the name of Ghana Health Service. But truly, as Deb and I argued in our paper, we think sex workers or men who have sex with men do have rights to health, enshrined in the fundamental human rights. And so whether they are legally outlawed or their activities are legally outlawed or not, as far as health service deliveries are concerned, they need to be seen as human beings before they are seen as sex workers. They need to be seen as human beings and receive the services that you and I, who are not sex workers, receive before they are seen as men who have sex with men.
Thank you for a beautiful overview of your approach to a very complex problem. My question is, what specifically have you been able to do to decrease stigma? What are the techniques that you have applied successfully?
Thank you very much. A very important question. I think is one of the easiest questions for me, in that I know the answer right away. And the answer is that we haven't been able. We haven't been able. No best practices, unfortunately. And stigma, we're looking at from 1980 to 2000, say 2020, that we have learned a lot about the epidemic. As I indicated, we have learned a lot about the epidemic to the extent that we compare to, diseases that existed before HIV. What we have learned over these past 40 years about HIV is like tenfold what we have learned about malaria and others. Yet that social problem or stigma has endured, and we seem not to have. And of course, there's no magic bullet, and that is why we don't have any best practices in Ghana. Stigma is still a major problem, and it doesn't seem to be decreasing at all. And if at all, it will not in the near future.
Thank you for presenting. This is so educational. I am from Africa. I'm from Cameroon, and Cameroon has been hit heavily with this virus. So I'm just, curious. Most African countries, they believe that HIV is a myth. Some countries, believe that it is, witchcraft. Mm-hmm. So I'm just curious, in Ghana, what is the popular belief? And then also, there's HIV-1 and HIV-2. In Ghana, what is the most prevalent virus that is that you see as you do your research? Thank you again.
Thank you. Very relevant question on the subject of whether or not all of us in the population see HIV the way you and I see HIV, right? So the truth of the matter is not everyone. It is not only in Cameroon. There are also people in Ghana who see HIV not the way you and I do, and we cannot brush that aside. There are still people, and you see, it's part of us as a society. It's part of our culture. It's part of our social upbringing, and so people sometimes, irrespective of your education, would not see hypertension as hypertension, would not see HIV as HIV. There are always those, bad eyes there. There are always those not sure how to put it, but those traditional conceptions of disease has implications on society's response, not only to HIV, but to other diseases. And so just as you have in Cameroon, although not significant, there are still people in Ghana who think that you got that HIV because your mother-in-law has cursed you. You got that HIV because your pastor, you've wronged your pastor. You got that HIV because you've done something, which doesn't make any scientific sense to you and I. But the fact that it doesn't make scientific sense to you and I doesn't mean we should, brush them aside. And brushing them aside only contributes to the problem that I'm here trying to advocate that we address. We need to understand where they're coming from to be able to help them. So it's a problem. And thankfully in Ghana, not significant, but the few who still believe in HIV denialism, apart from just the myth, need to be taken seriously, however few they are in our national response strategies.
Hi there. Thank you again. I'm happy I was able to catch part of this, especially the ending part after class. I'm really interested in climate change and specifically what that will mean for already vulnerable populations that, in the case of Ghana, food scarcity is already so prevalent in their minds and at the very front. Do you think, so scientists have projected that if we don't do anything in 10 years, it's going to rise to catastrophic levels. Do you think that things are aligned, or things could align for improvement in merging this marriage of medical and social to treat this and get rid of the stigma? Do you think they'll be aligned within those 10 years, or do you think that might not be the case? And if that's so, one of the outcomes of that food scarcity or any of these outcomes of climate change is climate migration. And that's usually within the own country. And then that brings it towards Africa as a whole. So I know that was a lot packed into one, but what are your thoughts?
Thank you. Climate change now, I think that of course there are still a few who would disagree that it is a major public health problem, but those who agree that it does or it is are many, including myself. And as you rightly indicated, here I am talking about national response to HIV. How does climate change come in here? But it does. We are talking about food insecurity and how food insecurity is contributing to our national failure to address HIV treatment-related issues. Climate change comes in a number of ways. Climate change can affect agriculture, Climate change can affect food production. Climate change can therefore affect food insecurity, and food insecurity is related to HIV. There are currently a number of scholars who are engaged in climate change and its relationship with ethics. People have argued, of course, there are ethical issues associated with climate change. Ethics about fairness, ethics about responsibility, and especially in the Ghanaian or African context, this ethics related to responsibility is one that we talk about. 2 years ago, when I was in a neighboring country, engaged in a conversation like this, there was this old man who indicated to us, a group of us, that we can only begin to address this climate change problem if we recognize that what we have today does not belong to us. That we should recognize that we have only borrowed the future from our grandchildren. And therefore, if you have borrowed something from someone, you need to take very good care of it. If we look at climate change in relation to our present day conditions, sometimes we get things wrong. If we have that, conceptualization of the impact of climate change with unborn generations, given that what we do today may not affect us, but could affect them, or will affect, would affect them severely, then we see the linkages of climate change with anything related to health that we do, whether HIV or otherwise.
Thanks so much for your talk. I want to ask a talk about that relates the world around here in healthcare in the U.S. With Ghana, since you've had such extensive experience in both places. One is more factual and one more attitudinal. The factual one, I was wondering whether you have an additional population with access to care issues for HIV, and that would be foreign workers who come to the country who may not be eligible for health care in your healthcare system, and because they're foreign workers, they may have relationships with sex workers, and so be part of the problem, and so you may have an international HIV problem. And I know there are countries around Ghana that are poorer. Ghana is fairly industrialized, and I'm guessing that you might have quite a few workers coming from places like Burkina Faso and so on. I could be totally wrong. The other is, since you've had so much experience in both countries, it seems to me one thing that happens, here you are from Ghana, you come here, you see what we do, and often our blind spots here are transparent to you. In the way we handle HIV, food insecurity, and stigma. And I wonder if you have any thoughts from your growing up in Ghana and working with people there that would be, say, ethics advice or general advice about healthcare, where you see some key issues we might do better on around here. So two questions.
Sorry, the second question, or should I address the first one and then get the second question later? Okay. So the first question relates to access issues, and thankfully, given my experience with the way healthcare is delivered to both Ghanaians and non-Ghanaians, the Ghanaian government, even in its scarcity of antiretrovirals, doesn't ring fence antiretrovirals for only Ghanaians. And I think apart from the fact that, of course, the resources, as I indicated, actually not Ghanaian, we are having those resources due to benevolence of bilateral partners, as I indicated, US through PEPFAR and Global Fund. Maybe that is one of the reasons why, but antiretrovirals that are being delivered to HIV positives in Ghana are not ring-fenced for Ghanaians, not only for Ghanaians. Anyone who is HIV positive can receive access. In terms of the prevention interventions that I talked about, currently are nearly non-existent. I mean, the primary prevention interventions that are usually delivered indiscriminately. So if you are given prevention education on radio, whether of course you are Ghanaian or non-Ghanaian, you would benefit. Billboard, you would benefit. So that is something that is refreshing. That no discrimination as far as HIV response or interventions are concerned. No discrimination by nationality. Then the second, I didn't get a second question. So
I'm just going to summarize the second question because we're short on time. What Professor Jameton asked is, given your perspective from growing up and working professionally in Ghana, but having good understanding of the situation in the U.S., do you have advice for us about what we should be doing differently here?
Okay. I think we can learn from each other. We have a lot to learn from you, and US obviously can also learn from us. And I think even my response to the first question would be one thing that US as a country can learn as far as healthcare is concerned, do away with protectionism. We see individuals as human beings before nationality. Although in some countries in Africa, medical citizens sometimes are invoked, and they say, "Oh, I'm a Ghanaian, so my government should provide for me." But when that government is providing for him, the same way they provide for other nationals, especially in when it relates to services that you have to pay for. So we don't care whether that money is coming from a Ghanaian or it's coming from a non-Ghanaian. The services are delivered. Of course, there would be some individual-based challenges, personal challenges related to service providers where the stigma and discrimination are talked about, but it's not widespread. It is not widespread. We also do have a national health insurance scheme in Ghana that's not working so well, but I do think, and most people have talked to the fact that it does help, especially the poor. And so those who are not able to afford services, who are part of this scheme, are able to get services to some extent, which I think, as I said, we can learn from US, and US can also learn from us in a number of ways. Thank you.
So thanks to you all for those excellent questions. It was a really rich conversation, and thanks again to Dr. Laar for a really beautiful and thought-provoking talk.